talk you're in the right place. I'm a family physician. I work in Markham, Ontario. I'm the chief of family medicine at a hospital called Oak Valley Health, or Markham Stouffville Hospital. And I'm an associate professor at both the Department of Family and Community Medicine at University of Toronto and the Department of Family Medicine at Queen's University. So academically, they like when I post all that stuff on the first slide, so there you go. Okay, so just a few disclosures. So this slide basically shows all of the things that I get remunerated for, having mostly to do with either leadership positions that I have or academic talks that I give. They are all listed here. Every organization that is listed on this slide is not for profit. Okay. This slide shows all of the talks that I've given where I've been remunerated for my time. All of these talks have been accredited for Main Pro credits through the College of Family Physicians of Canada, and they've been in various places, and the various sort of topics are written up there. I don't have any specific relationship with any of these organizations. I've just been invited to give talks. Let's see if this works. Okay, there we go. So I do have one relationship with one drug company. Pfizer invited me to sit on a couple advisory meetings for them having to do with COVID-19. One had to do with how we get the word out more about vaccination, and the other one had to do with whether or not we should use Paxlovid in long-term care. I can tell you that most of my contributions to those discussions were actually to be narrowing the right populations of those treatments, but I was remunerated for my time. Aside from that, I don't have any relationship with any other pharmaceutical industry, and I've only had 2 meetings in my life with Pfizer. Everything else is not applicable. When I was the provincial primary care lead for an organization called the Ontario Renal Network, I haven't been with them for 5 years, I did receive in-kind support when I started giving this talk. And anyone in this room that has ever heard me speak on chronic kidney disease today, I promise you, you won't be hopefully disappointed. I've updated the talk, especially the second half. But at the time I was first doing the talk, I did receive in-kind support from that organization. And my FMF registration fee was waived for today because I'm speaking at the conference. And finally, the FMF Scientific Planning Committee reviewed what was going on in today's talk. I've presented this at other conferences. I've gotten feedback. I've updated it based on that, tried to make it better. And I'm solely responsible for the scientific validity, objectivity, and completeness of the content of my presentation. Okay. I don't know if the IT people in the back can make the slides on this monitor bigger. It's very hard for me to see them. If not, it's fine, but I might have to turn my neck a few times here and there. Okay. I haven't changed this slide to a big white X on a black background. I just can't seem to be doing it. But I am still on Twitter. If anyone in this room is on Twitter and you want to tweet some stuff from this talk, hopefully it's positive, my Twitter handle is written there. It's at Alan_K_GrillMD. The hashtag for the conference is FMF 2023 or hashtag MyFMF. And then the CFPC has its own Twitter or X handles. The E is for the English version, the F is for French. So there you go. That's my social media plug for the day. Okay, so there's 4 learning objectives for today's talk. I'm actually going to do a little walking around because I'm having trouble seeing everything. So we're going to identify a practical clinical algorithm that can be implemented in primary care practice to help manage patients with chronic kidney disease. I'm going to talk a little bit about that algorithm. We're going to differentiate patients with increased risk of advanced CKD using something called the kidney failure risk equation. And if anyone in this room hasn't started using that equation, I'm really hoping by the end of this talk, you will use it, you'll understand why you're using it. It will actually give your patients, that's awesome, guys, thank you. It will also give your patients a lot more confidence and less anxiety around your diagnosis of chronic kidney disease. We're going to talk a bit about blood pressure targets with regards to CKD, and we're going to spend some time on SGLT2 inhibitors. When do you use them? Why are we using them? What's the evidence behind them? It's been quite a progression in terms of treating this condition with SGLT2s. And finally, I added this learning objective when I was updating this talk, so it wasn't in the write-up for the conference, but finerenone is this new drug that I'm going to talk about today. And the reason why I'm going to talk about it is because I think there has been some misinformation given to family physicians about this drug. I think some of that misinformation is promoting its use more than it should be used. I'm going to give you my opinion on that based on the evidence. And hopefully by the end of the talk, you'll have a little bit more of an understanding of where that drug fits in to CKD. The other thing I'm just going to mention before I get into this is, I'm a family doctor like all of you. This talk is going to be practical. So I am going to talk about the evidence behind what I'm talking about, but I'm hopefully not going to have too many slides that are super busy. When you leave this room, you will be more confident in how to diagnose and manage CKD. You will realize how easy it is, and that the majority of patients with this condition, even though some of them have other comorbidities we'll talk about, you can actually manage on your own. You do not have to refer them to nephrology, and I will make it very clear which patients I think do need that type of referral. Okay, so let's talk about CKD. So I will not use the term chronic renal failure. It's outdated. The new term is chronic kidney disease, CKD. All right, so don't say chronic renal failure anymore if you're using it. Although in Ontario, I think the OHIP billing code still says chronic renal failure, but that's another story. Acute renal failure is also outdated. The new term for that is acute kidney injury, or AKI. We're going to talk a tiny little bit about that and why it's important to know about it, but this is not a talk on AKI. And if you think about it, why would we say renal failure? Don't we want to get renal success, right? Aren't we in the business of being positive? So that's a happy kidney that we're trying to achieve in all of our patients. That's probably about as funny as this talk is going to get today, so there you go. Okay, so what is the prevalence of chronic kidney disease? So 10% of people living in North America have this condition. It's about 20 million people. It's still a lot of people. 25% of North Americans over 65 have CKD. So a lot of this disease you will see in your more elderly patients. And we're going to even talk about whether you have to pay that much attention to it in elderly patients and when you have to pay attention to it. And the other interesting thing is that only 3% of all the people diagnosed with chronic kidney disease progress to something called end-stage renal disease, or some people call it end-stage kidney disease. That's where you need renal replacement therapy, like dialysis or renal transplant. Now, 3% seems like a very small number, right? So in your practice, you may not even have anyone that's on renal replacement therapy, and that's okay. But you're going to see a few over time that progress, and the key is, how can you intervene early to actually prevent somebody from getting to end-stage renal disease? That's the key question. Okay. Now, according to the CFPC, the last time I checked, there are 99 different topics family physicians are supposed to know. At least that's what we tell our residents, right? When you finish residency, you're responsible for 99 different topics, although it sometimes seems like 500 different topics. So I've got to sell to you why CKD should be one of those topics that you prioritize in your practice, as opposed to osteoporosis, heart disease, all these other things that we see, which we should obviously be trying to give equal attention to. But here's my pitch for CKD. So 90% of people that you diagnose with this condition are actually at low risk of progression and should probably only be followed by you. No? And if there's any nurse practitioners in this room or any nurses in this room, depending on where you work in Canada, maybe more rural areas where you're providing primary care, this applies to you as well. So 90% can be managed by us. And I would argue that in long-term care, 100% of patients with CKD should be managed by whoever the most responsible physician is, which typically across Canada is a family physician. I rarely see nephrology get involved in somebody in long-term care if this is a chronic disease, not something brand new. So I would say, like, in that population, we should, whoever is practicing that type of medicine, I did long-term care work for about 13 years, it should all be managed by family physicians or primary care. If you identify it early, you can actually make a difference. You can prevent people from progressing to end-stage renal disease. We're going to talk about those interventions. The other thing I would mention is that for those of you that are in long-term care, one of the things that I often promote are medication reviews. Now, most long-term care homes will say you're supposed to do a med review. Some do it every 3 months, some do it every 6. You have to speak to your medical director. But one of the most important things about med reviews, aside from the fact that if you take their diagnosis list and you can't match it to every medication they're on, you should think about deprescribing some of those medications. So that's always a fun exercise to do. But the second thing is, it makes you ask yourself the question, do I have to dose adjust any of the medications my patients with chronic kidney disease are on because of their chronic kidney disease? And in the elderly population, because I've already mentioned to you, at least a quarter of people over 65 have this condition, it's a great exercise to make sure that you're not treating them with the wrong dose. And we'll get into that a little bit later, but that's another reason why med reviews are so important, okay? Chronic kidney disease is associated with cardiovascular disease. So we know that people with CKD also have things like diabetes, coronary artery disease, heart failure. There's a huge interaction between those. And so if you're treating one, you're actually preventing or helping to treat the other. And finally, for those people that are progressing, and there are going to be some, we want to actually get them to nephrology, if appropriate, as early as possible. And there's several reasons for this. Sometimes it's because they can help us out. We might have missed something. They can intervene, and then we learn something. But for other reasons, like when someone's progressing, you've done everything you can, they're still progressing, and they're on their way to end-stage renal disease, and that does happen. The earlier they can see somebody that's going to treat that and prepare them for it, vascular access, all these things. There's a whole team of people that work with these patients. It's a much better quality of life for them. There's a lot less morbidity. Although renal replacement therapy has its renal replacement therapy has its own issues with quality of life. If you intervene early, it's much better for the patient. And the only way they can get intervened that early is through you, the primary care provider or family doc. Okay, if you haven't checked out KidneyWise, this is an Ontario algorithm. I'm going to go through it today. It was produced by the Ontario Renal Network. I'm not going to really talk about them today. They are going to be updating this again in the next year. So if I give this talk again next year, it might be even more updated than it is now. But it's worth checking out. www.kidneywise.ca, very simple. Everything I talk about today will be on that website, so you don't have to run and check it now. The other thing I'll just tell you is I applied for an endorsement at the College of Family Physicians of Canada a few years ago. Now, I worked for the CFPC up until the summertime. I had a great time with them for 7 years, and I moved on to something else. But the endorsement process now is completely different. They're now focusing more on guidelines, and it has to do with resources and people power and stuff. But at the time when you could send your work in and get it endorsed by the college, I just want everyone here to know that that algorithm that I mentioned that I'm going to talk about today was actually endorsed by the CFPC. So nationally, it applies. It's not just something specifically for Ontario. Okay, there's 3 parts to the toolkit. One is the algorithm. I'm going to focus mostly on that today. One is an evidence summary. If you want to read a little bit more into the evidence behind it, which again I'm going to cover today, that's part of the toolkit. And then there's a nephrology referral form. I will cover that today too, but some people can actually download this form into their EMR. They can use it even if you're not working in Ontario. You can send it to a nephrologist where appropriate in your own province, because the Canadian Society of Nephrology knows all about the toolkit as well. And so again, it's just a useful tool you can check out if you want to use, or if you want to design a template in your own office, whatever you like, it's all there for you to use. Okay, so these are the 4 guidelines that we keep going back to when we're putting together the toolkit. I only raise this because there's nothing more frustrating when you get some sort of algorithm or kit that an organization comes up with, and then you're like, yeah, but I read the guideline on lipids, and it said something completely different than what your toolkit says. So we tried our best to go through these guidelines and align them wherever possible. So in other words, what I'm telling you today hopefully will not make you have to go out and read all of these individually. We really did try to incorporate it into the work that we did. Okay, so the first thing is, who should be tested or screened for chronic kidney disease, right? Like, where should we focus our attention? So it's actually pretty easy. Anybody with diagnosed hypertension, anybody with diagnosed diabetes, or anybody that you know already that has established cardiovascular disease. All of those people should be tested for chronic kidney disease. We'll talk a little bit more about how often you should test them, but if you haven't, they would be very, very appropriate. There were 2 other categories that were added to the algorithm when it was updated back in 2018. So First Nations, Inuit, Métis, over 18 years old, those patients should be screened regularly for chronic kidney disease. Now, originally we thought it was because there was such a high prevalence of diabetes in those populations that, well, because they have diabetes and there's a correlation with CKD, we should test them. But it turns out that there's now some evidence to show that genetically that population may be higher risk for CKD, and so we don't want to miss them in terms of the screening process. Secondly, if you know someone in your practice that has a first-degree relative with chronic kidney disease, and again, This is where it gets tricky, because then you have to think to yourself, okay, when do I ask that question? Do I do it at the wellness visit or the periodic health exam? When I'm going over the family history, do I now have to ask if someone has CKD? It's hard. I'm not suggesting that you have to add that question to every single one of your visits. But if you happen to know somebody in your practice that has a first-degree relative of CKD, specifically someone that has more a severe case of CKD, it's probably worth screening that patient. And again, in most wellness visits, and we could have a whole talk about, from choosing wisely about how many blood tests we should order and when we should order them, you're probably ordering, You're probably ordering serum creatinines on a lot of your patients anyway, but I'm trying to put it in a more organized context. And finally, if you have a patient in your practice that meets the above criteria, but you think their life expectancy is less than 10 years, and this usually focuses more on people that are elderly, and obviously this, what I'm talking about today, doesn't apply with somebody who's receiving end-of-life care, we do not recommend screening them for CKD, because the interventions that you're going to do are probably not going to make a huge difference in terms of their overall life expectancy. So we're not trying to cast the net too wide here. We're trying to focus in on these patients with risk factors. Okay. There are 2 tests you have to order. It's simple. You have to order a serum creatinine, and hopefully it will come with an eGFR, the estimated glomerular filtration rate. It's a measure of kidney function. And you have to order a second test that people still tend to not order enough of, which is a urine for albumin-creatinine ratio. This is where we're measuring kidney damage or proteinuria. Proteins are spilled into the urine. Please don't order 24-hour urine collections. Most patients don't follow your instructions. Most of the time when we instruct patients to do it, we tell them the wrong thing. And then when they do the test and it's wrong, they're very angry at us because they're like, I spent 24 hours doing this, and now you're telling me I did it wrong. The urine ACR is a simple urine test. It's all you need. Don't order 24-hour urines. Leave that to the nephrologist. They can analyze it, have rounds on it, have fun talking about it. Okay. The other thing that's really important is don't ever screen somebody with those risk factors if they're sick, if they have something called an intercurrent illness, right? So for instance, and I'm exaggerating, if somebody comes to your office and they've just run a marathon and they have diabetes, don't screen them that day for chronic kidney disease, right? Because they're probably a bit dehydrated. Or if somebody comes to your office because they're acutely ill, they have a gastroenteritis, don't say to yourself, oh yeah, you also have hypertension. I forgot to screen you for CKD last year. I'm going to do it now. Bad idea. Again, dehydrated. You'll probably get a result that doesn't represent chronic kidney disease. If it's abnormal, it probably represents what we call an acute kidney injury. And if it's an otherwise healthy patient, once they recover from that illness, their kidney function will be fine. So just know, if they're sick, don't screen them. Screening should be asymptomatic at a time where they have no symptoms, that sort of thing. So let's say you identify who's at risk. We've gone over those categories. You order the serum creatinine / eGFR and a urine for albumin-creatinine ratio, okay? And one or both of those results come back abnormal. What do? So this is called the detection part. So assuming that there's no intercurrent illness, if the eGFR is less than 60 mils per minute, that is abnormal. If the urine ACR is greater than 3 milligrams per millimole, and again, depending on where you work in this country, you might get 3 different values for the ACR. Focus on the milligrams per millimole. Just ignore the other units. So if it's over 3, that's also abnormal. Now, you don't have to panic. You just have to say to yourself, okay, if these are abnormal, I can't make the diagnosis today because the definition of chronic kidney disease is they have to be sustained abnormalities for at least 3 months. So you just make a note in your EMR, and if you're not using an EMR, make a note with your admin assistant or something to recheck that patient in 3 months. It's very simple. You do the screen. If one or both of those are abnormal, do it again in 3 months, and then I'm going to tell you what to do at that point. That's the key. But, so I said one test result is not enough, and it's persistent over 3 months. Sorry, I just repeated myself there. But let's say you get that first result back and you get that pit in your stomach, right? Or like sometimes when we're checking our labs at home, you really want to go to bed and you're like, oh, yeah, I'm a little worried about this. I want to just do something. If you get that feeling, start to think about, is there some sort of clinical concern going on? So let's say you get an eGFR back and it's like way lower than you thought, like it comes back at 40 or something like that. The last time you did it on the patient, it was like 75 and normal, it comes back at 40. So if you're concerned that the result you get back might be worse than you expected, just repeat it in 2 weeks, right? Like assuming the patient's feeling fine, I wouldn't wait 3 months, I'd repeat it in 2 weeks. And while you're repeating it, start to think about some of the things on this list that might be going on. Have they been popping those NSAIDs for those sports injuries that they aren't telling you about? Are they on some sort of herbal remedy that's interfering with their kidneys? Did they go for some sort of diagnostic imaging test? Maybe you ordered it, maybe you didn't. They had contrast dye, and all of a sudden that sort of manifested itself as them having chronic kidney disease, at least an AKI in that context. Do they have some sort of obstruction? Again, men with BPH, often they present with decreased renal function because of post-renal obstruction. Are they volume depleted? Were they somehow dehydrated when they went for that blood test that we sort of covered? And again, even if you order it in another context, so another great example would be, if you do long-term care work, I keep going back to long-term care. Every year we're asked to do an annual renal test on the patient. It's usually just an EGFR or serum creatinine, because if there's an influenza outbreak and we want to use Tamiflu, which is part of these protocols, we have to dose it based on renal function. So let's say you're doing that test for that reason, and it comes back like as a number you weren't expecting. Think about what the cause could be, right? It might just be CKD, and maybe it's been stable and you haven't tested in a while. But if you're not sure, repeat it 2 weeks later, and if it's an intercurrent illness, you can deal with it. Maybe this is just an AKI. And if it's not, it's probably CKD, and you're going to repeat it again in 3 months anyway, okay? So that's the only thing I want to mention there. The other thing I just want to say is, don't add renal ultrasounds as part of your screening process. You know, we see this a lot. People want to try to diagnose them with CKD, and then everybody gets a renal ultrasound. You don't need a renal ultrasound to diagnose this condition. In fact, it will probably result in other headaches for you if they find these other incidental findings on the renal ultrasound. I would only do a renal ultrasound if you're looking for a certain diagnosis, if you think someone's obstructed, there's symptoms. But as a screening test for CKD, I don't recommend you ordering it. Okay, so let's assume you identified the patient who has a risk factor. You ordered the EGFR, the serum creatinine, and the urine ACR, and they do not have an intercurrent illness. The first result comes back, and it's abnormal, okay? So you repeat it 3 months later because you're not worried about an intercurrent illness. What happens then? Okay, so 3 months have gone by, and there's 3 possible scenarios that could happen. So scenario number 1 is, on your repeat test, the EGFR is normal. It's greater than 60. The urine ACR is normal. It's less than 3. This person does not have chronic kidney disease. Oh, thank goodness. You can reassure them the first test was abnormal for whatever reason. They're fine. So the question is, when do you retest them? This we don't have a great answer for. So the advice we're giving is, if a patient has diabetes, you should probably test them at least once a year for chronic kidney disease. If they have other risk factors, you decide. Sometimes you'll do it at your wellness visit. I do wellness visits on most patients, or periodic health exams, every 2 years. Sometimes patients don't show up for 3 or 4. So I'll probably do it around the wellness visit, but we don't have a great answer. What we do know is that if they have diabetes, you should probably be testing them more frequently than some of the other risk factors. And please, if somebody doesn't have CKD, don't label them with it. There's insurance implications, all these things. That's why we repeat the test 3 months later. Okay, that's the great scenario. Then there's the worst scenario. 3 months later, the EGFR comes back, it's really bad, less than 30. Okay, and again, that would be a bit of a shocker if the first result wasn't even close to being that low. Or the ACR comes back super high, greater than 60 milligrams per mil. In those scenarios, we know the person has CKD because it's that second abnormal result in 3 months. It's persistent, it's sustained. These people should see nephro, right? We're getting to the point where it's starting to get to the progression part. Nephro should get involved, even if it's an e-consult, a phone call, in-person consult. Nephro should see these patients. What do you do while you're waiting for nephro to see them? In some places in Canada, that might be 9 months, right, depending on where you work. So we advise you to send some investigations that you can also look at while they're waiting for the referral. Our urine RNM and electrolytes are done specifically because you're looking for CAS, signs of glomerulonephritis, IgA nephropathy. If you make that diagnosis, the referral wait time will probably decrease significantly. You're looking for electrolyte abnormalities simply because potassium can be something that gets affected with chronic kidney disease. And then again, most nephrologists want to know, is this person anemic? Do they have bone metabolism issues? So calcium profile and CBC are key. And remember, just because you're referring them doesn't mean you're never going to manage their CKD at all. When we go through the management, you can still be an equal partner in taking care of these patients. And finally, this is the category that is the most likely to happen, assuming that the result after 3 months isn't normal. So somebody's EGFR is now between 30 and 59. So it's less than 60, but greater than 30. And their ACR is abnormal. It's greater than 3, but less than 60. So again, that person has CKD, persistent abnormalities for at least 3 months. The workup is a little bit less. So it's just the urine RNM, routine and microscopy, and electrolytes. We don't do the whole anemia workup in this case because this patient is not progressing to the point where we start to worry about those other manifestations of chronic kidney disease. And then the question is, what do you do with them? So you've made the diagnosis, you order these tests, let's assume the tests are fine, then what? Like, what's the management like after that? So this is what the nephrologist would tell you to do. And by the way, I say this tongue-in-cheek because I know a lot of nephrologists were friends, they know who I am. But this is called the heat map, right? There's a little bit of red, it's hot, you don't want to touch it. And then the green is like, oh, it's calm, it's like green means go. The yellow's kind of like, oh, we're not sure what to do. If you follow this, look how complicated it is. They want you to break down the urine ACR result with the EGFR, depending on where you fit, the number of visits per year. Like, nobody understands this. No family doctor is going to follow this. Forget it. So we put a big X through that. So here's what we came up with. If you have the person in this middle category, you're not referring them, but they have CKD, here's what we recommend. Do an EGFR and a urine ACR every 6 months for 2 years, okay? You're just following them. If during those 2 years everything is stable, and I'm going to give you some advice in a minute about what to do if it's not stable, then you can switch them to doing it every year. So one more time, you make the diagnosis, you're not referring them, check the EGFR and the urine ACR every 6 months for 2 years. Assuming it's stable, do it once a year. Your EMR reminder can do this work for you. Patient doesn't even have to come in. You get the reminder, fill out the lab rec, email it to the patient, have them pick it up. Whatever you do in your offices, I don't want to create more admin work for you. We have enough. But you can get this all done. You can interpret the results. Patient doesn't even have to come in. They love it, okay? All right. The kidney failure risk equation. So I'm going to do this very briefly. There's a couple, my slides are going to be shared on the app. So if you haven't seen these links, you should check them out. But basically, the kidney failure risk equation is a validated equation. It was created actually by a nephrologist and a team from Manitoba. And basically what it does is it takes into account the age of the patient, the sex of the patient, the EGFR, and the urine ACR. You put it into a formula that is done on this app for you. This is completely dummy-proof. And what it does is it gives you a 5-year prediction of what percentage chance your patient will end up with end-stage kidney disease. Now, why is this interesting? It's interesting because when you diagnose a patient with CKD, the first thing that they probably, well, if they're paying attention, they'll want to know is, am I going to need dialysis? Or how bad is this going to get? And up until now, I'm not even sure how we'd answer that question. We'd say, well, it's mild. We're going to monitor it every 6 months. I'll let you know. But this equation is really great because when they validated it, what they came up with, and I will show you this on the slide coming up, if somebody's 5-year risk of developing end-stage renal disease is less than 5%, you can actually tell them they really don't have to worry. Okay? Now you would think to yourself, so does that mean, Alan, if it's 6%, which means 94% chance in 5 years they're not going to have dialysis, they should worry about that? I know it sounds really crazy. But when they've done the studies, what they've showed is that people that have a more than 5% risk of developing dialysis in the next 5 years, that's a sign of significant progression. They're at risk. So we can intervene and do a bunch of things, but those are the people you want to keep an eye on. And when someone doesn't fit into that category, you can actually reassure them that, hey, patient, I got this. You're not at risk right now for end-stage renal disease. I'm going to manage you. This is just something that you have. We're going to deal with it together. You can provide incredible reassurance with this equation. So even if you use it just as an exercise to reassure your patient, I highly recommend it, although I'm going to tell you in a minute why I'm introducing it specifically. So if you look at our algorithm with KidneyWise, this is the reasons why we think people should be referred to nephrology. So if you look at the first category, I've already told you about this, it's when the EGFR is less than 30 for at least 3 months. That's assuming they have more than 10 years life expectancy, they're not palliative, that sort of thing. Same with urine ACR. If it's greater than 60, persistent for 3 months, nephro should be involved, right? These people are at high risk of progression. The other one that's hard to remember, but I'm going to tell you anyway, is that if you have a patient with an EGFR at any point after you've made the diagnosis where the EGFR is less than 45, and as you're testing them, whether it's every 6 months or even every year, because sometimes, if they're stable, you'll go every year, but if they decline more than 5 points or 5 mils per minute within that 6 to 12 month period, and then you confirm that 2 weeks later, so let's say somebody's EGFR is 44, and then 6 months or 12 months later you do it, it's 38. And then 2 weeks later you do it again, it's still 38. So it wasn't some sort of blip. That is a sign of aggressive progression of CKD. You don't want to just say to yourself, okay, 44, 38, no big deal, I'll watch it. Those people really need to be referred and make sure why they're progressing. Is their management up to speed? It makes you reassess what you're doing, which we'll get to in a minute. The one that was removed, you can ignore. It's just there for people that are familiar with the algorithm. And finally, if the KFRE 5 years is greater than 5%, you should actually consider getting nephrology involved. And you'll be amazed how many patients you have whose KFRE is not greater than 5%. So by introducing this equation, I promise you it's not going to create a lot of work for you. It's probably going to give you more reassurance. But if it's more than 5%, those people are at high risk of progression. They should be referred. Okay, we're going to go through this really quickly. The algorithm talks about it. With hyperlipidemia, we're more aggressive with people with CKD. So to give you an example here, if they have diabetes and greater than 18 and they have CKD, you should have early conversations about statin therapy. If they have CKD and no diabetes and they're older than 50, you should have a serious conversation about it. And finally, over 18 with either coronary artery disease, a previous stroke, or if their Framingham is greater than 10%, so in that intermediate category, but they also have CKD, you should consider statin therapy. And this has to do with the fact that the number needed to treat for those patients is actually less in terms of benefit than someone who doesn't have CKD using the same Framingham risk factors. Okay? I'm not going to tell you how to treat diabetes. You know how to do that. So this is just a thing on statin therapy, diet, exercise, don't smoke, all those things. Okay, the other thing too, NSAIDs. So NSAIDs are bad for people with CKD. Now, I'm a realist. You're going to have some patients with OA. Those patients will tell you they can't live without their NSAIDs. I respect that. We don't want to turn somebody's quality of life into mush. But if somebody with CKD is taking NSAIDs on a regular basis, you have to make sure they understand that they're putting themselves at risk. If they understand that risk and they want to continue to take it, you have to be very vigilant at keeping an eye on their chronic kidney disease. For those patients of mine that have CKD that are on NSAIDs regularly, I test them every 3 to 6 months. And if I start to see blips, I tell them that if they don't come off, it's probably going to result in a worsening situation for their kidney disease. And then we have another discussion. So just be mindful of NSAIDs. When you send people for radiology investigations and contrast is needed, most of the time you get asked to send in an EGFR. Please send that in, because we can put people with CKD that's mild into an acute kidney injury with contrast eye. Then their CKD gets worse. They never get right back to baseline. We can avoid that problem. Diuretics is another medication you have to be careful about in terms of monitoring. And if somebody gets really sick, everybody knows about the SAD MAN sick day medication list. So there's a bunch there, sulfonylureas, metformin, diuretics, NSAIDs, SGLT2 inhibitors. I think I'm missing one of them. So just know that if somebody gets sick and they're on those meds, always remind them, stop the meds, let them get better, go back on their meds. It's okay if their blood pressure goes up a little bit or if their, diabetes is a little bit out of whack for a couple of days. You don't want them to go into acute kidney injury and have worsening renal function. Okay. So here's the SAD MAN's list. There you go. I think I forgot ACEs and ARBs. There you go. Terrible, terrible guy. Okay, don't forget about the renal dose for medications. It's just a good reminder if somebody's got CKD, always know how you're dosing them. And remember, you don't have to use creatinine clearance. Pharmacists love it. You can use it. But you can also use EGFR. And a lot of the resources that we use when we're looking up medication dosing, including RX Files, which, by the way, I have no affiliation with them, you can use EGFR just the same unless somebody is super, super thin and frail or super, super obese. Most of the time, the EGFR can be used as a guide as well. Okay, let's quickly go over hypertension. So this is from Hypertension Canada, and basically what it says is there's certain categories of people that are high risk. They're listed here. Over 75 would be one example. The other example is chronic kidney disease. So if somebody has chronic kidney disease, according to Hypertension Canada, you should actually consider more aggressive management of their hypertension. So what does that mean? Well, if you look at this chart, it means that you should be targeting a systolic blood pressure of around 120 millimeters of mercury, okay? Now, I know what some of you people are thinking, and I think the same thing. What patient of mine who's got a blood pressure of, let's say, 125 is really going to be sold on lowering it to 120? And you make a very good argument. I have enough trouble getting people on one blood pressure medication when they're not controlled, let alone adding just to get them to the thresholds that have nothing to do with CKD. But they should be aware of the fact that the more aggressive we are with their blood pressure, the better they're going to do. And that's where the 120 comes in. This does not include people with diabetes. If you have a CKD and diabetes, the blood pressure target is still 130 systolic. So what did our algorithm decide to do? It went with Hypertension Canada. It's listed here. But remember, the SPRINT trial did not include a bunch of the patients listed here: frail elderly, nursing home, stroke. So just know that not every patient with CKD applies to the 120. Not every patient is going to want to go as low as 120, but just be aware that the lower you can go towards 120 with CKD who don't meet the exclusion criteria, the benefits are there in terms of cardiovascular benefit, decreased chance of their kidney disease getting worse, okay? It's a conversation you're going to have with your patient. And remember, this had to do with automated blood pressure cuffs. The studies were not done with the manual cuffs. That's the other thing. Okay, so go slow or sprint, you decide. This is an old slide I used. Again, that's a bit of humor if you're falling asleep at this point in the talk. Okay, the last thing I want to talk about before we get into the drugs, because I want to spend some time on that, is what do you do with urine ACR? Okay, so this is very simple. If someone has CKD and diabetes, right? You're going to follow their urine ACR. If that urine ACR is greater than 3 on at least two measurements over 3 months, those people should be on an ACE inhibitor or an ARB. Never put them on both. They should be on one or the other. It decreases the progression of kidney injury, and they should be on it. If you have CKD alone, no diabetes, the only reason to put them on an ACE or an ARB is if their urine ACR is consistently higher than 30 milligrams per millimole, and they have hypertension. So if they have hypertension and the elevated urine ACR, you should be treating their hypertension with an ACE or an ARB. That's the key point with the albuminuria. If you just want to look at blood pressure once you've thought about urine ACR, if somebody has hypertension with CKD and diabetes, you can treat them any way you want. Obviously, if they have elevated urine ACR, I just told you use an ACE or an ARB first, but if they don't, use whatever treatment you want to use. If they have CKD alone and they have hypertension, same idea. Use whatever drugs you like. If their urine ACR is not greater than 30, you can take whatever approach you want. But we wanted to break it down with regards to blood pressure and urine ACR. Remember that every time you make an adjustment of some of these meds, especially diuretics, ACEs and ARBs, you have to check their lights and creatinine at least 2 weeks later, looking for an increase. And you can expect up to a 25% reduction in EGFR. If it's more than 25%, you might want to take a pause on the med you just gave them, figure out why that's happening. Could it be renal artery stenosis? You can always ask a nephrologist for a little bit of help on that one. Okay, let's talk about SGLT2 inhibitors, all right? So the first time we looked at these drugs and CKD, we only looked at them in the context of diabetes. These are 4 trials that were done a few years ago. Every one of these trials had patients who had CKD and diabetes, all of them. The other thing about these trials is the CKD patients all had heavy proteinuria, heavy, like high urine ACRs, like at least greater than 30 milligram per millimole. So these were people that were sort of on the advanced spectrum of CKD. The first 3 studies here, what they showed us was they said, if you have CKD and diabetes and we put you on an SGLT2 inhibitor, you actually get cardiovascular benefit. And what we've taken out of that, because a lot of the patients in the trial had CV disease, most of your patients with diabetes who have cardiovascular disease, most of those people are probably being put on SGLT2 inhibitors. And if they have CKD, it just sort of added to that evidence. When Credence came out, which is the last trial on the right, I think, of this, they looked at renal outcomes. They looked at progression to end-stage renal disease. They looked at a decrease in eGFR to 40%. They looked at death from renal disease. Same population, CKD and diabetes, put them on an SGLT2. Turns out they had risk reduction for CKD. So it was the first time we actually saw the fact that SGLT2 inhibitors help patients who have CKD and diabetes. This slide, and then I'm just highlighting some things I just talked about. This slide just shows those same 4 studies. The only difference is Credence was the only one that had a primary outcome for the renal effect. The other 3 studies were secondary. So I'm only highlighting this to show you that Credence had the main benefit for CKD. Okay, what does Diabetes Canada tell us? Well, they tell us that if you have diabetes and you have chronic kidney disease, you can start an SGLT2 inhibitor for the following reasons, right? One is to reduce the risk of nephropathy. We saw that with Credence. 2 is there's an impact on hospitalization for heart failure. So if the patient has a history of heart failure, there's benefit of there too, again, in the context of CKD and diabetes. And finally, we know about the cardiovascular benefit. So none of this information is probably new to you at this point. Okay, this is the crazy slide that Diabetes Canada puts out, and it just reiterates everything I just talked about. When is the most appropriate place to use SGLT2 in someone with diabetes? And if you notice under CKD, SGLT2 is there, whether you have cardiovascular disease or CKD or both. Okay. But what happens if you have CKD and you don't have diabetes? What do you do then with SGLT2 inhibitors? So there's been 2 trials that have come out. You're not going to love the final conclusion of this, but I'm going to tell you the evidence anyway. So DAPA-CKD looked at dapagliflozin, which is one of the SGLT2 inhibitors, against placebo. Now in this trial, 1/3 of the patients had CKD but no diabetes, right? So it still had a lot of people with diabetes, but 1/3 had no diabetes. The lowest eGFR they allowed was 25. I'm only telling you that because we've gotten lower and lower eGFRs that we can use these SGLT2 inhibitors in. It started at 30, went to 25, now I think it's down to 20. The mean eGFR was 43, so it's below that 45 threshold I talked about earlier. And they all had heavy proteinuria. It ranged from a urine ACR of 23 up to 565. I don't see people with urine ACRs of 565 in my practice. I just don't see it. But these were pretty sick CKD patients. And it turns out when they looked at the endpoints for both cardiovascular disease and death related to CV disease and prevention of renal outcomes, including CKD-related death, in patients with CKD alone, they benefited. So now we're in a situation where like, oh, interesting. So if you just have CKD, what's the role of SGLT2 inhibitors? So then they had this other study called EMPA-KIDNEY. They used empagliflozin, another SGLT2 inhibitor, against placebo. This time, over half the patients in the trial did not have diabetes. The lowest eGFR was 20, for the reasons I said before. The mean urine ACR was 37, okay? And again, they looked at the primary endpoint for both renal and cardiovascular. The circle diagram just goes to show you that they tried to widen the spectrum of all different types of CKD patients in this trial. And the most important thing to know from this trial is that in order to get into it, every single patient had to be on an ACE or ARB. Why? Because of the fact that most of them had heavy proteinuria, we just talked about before. If you have CKD and heavy proteinuria, if you have hypertension associated with that, most of those people end up needing ACE or ARB therapy, right? So that's what's important here is that you're still starting with that ACE or ARB therapy in this patient population. And what were the results of that study? So this is just a fancy way of showing you that the events for both renal and cardiovascular were less if you were on MPAG versus placebo. So that's pretty clear from this diagram. This is hard to see, but I just want to point out, if you look where the big squares are, to the left of the line where MPAG is better than placebo, what this is really showing you when you dig down into the evidence is that although people with CKD alone did benefit with MPAG, the people that still benefited the most in this trial were those with CKD, diabetes, and heavy proteinuria. Okay? So I'm going to say that again. CKD alone benefited, but the people that benefited the most were still CKD with diabetes and heavy proteinuria. Okay? So what's the conclusion? The question is, are the benefits clear enough to treat every CKD patient? In other words, even the ones without diabetes who don't have elevated urine ACR with an SGLT2 inhibitor? And the answer is, I think the jury is still out. So I don't want to leave you at the end of this talk thinking that every CKD patient needs an SGLT2 inhibitor. We don't know. There's other trials coming. I think the evidence with CKD and diabetes is clear. I think CKD alone is still unclear. So I'm giving you advice maybe to not do something until we have more evidence. Okay, I want to get to questions, so let's keep going. You should all know about the side effects of SGLT2 inhibitors before you put a patient on it. Be cautious about the fact that if a patient's really thin, they might lose weight on the drug. You got to watch their weight. It will lower blood pressure. You got to make sure they don't get hypotensive. There's some mycotic infections. There's some evidence of increasing the risk of amputation, although it tends to be in people with CKD and diabetes. So just make the patient aware of that. Again, these are some of the overall benefits you get from it. We've covered most of them. It also helps with blood sugar control if you have diabetes. And finally, dose adjustment, right? So I think right now, most of them you can dose up to an eGFR of 20, as low as an eGFR of 20, but always know what the lowest eGFR you can use when you're dosing them. Okay, last thing, finerenone. What is finerenone? Finerenone is a mineralocorticoid receptor antagonist, okay? It's a type of diuretic. Health Canada's indication for this drug is for people with CKD and diabetes. Let me make this clear. People with CKD and diabetes, okay? And it's supposed to add onto the standard of care. What's the standard of care for people with CKD and diabetes? If they have heavy proteinuria, it's usually an ACE or an ARB, and as I just said before, you're adding on an SGLT2 inhibitor for that added protection, right? That's the standard of care. Now, Health Canada is suggesting you could add this on as a third drug, okay? And again, it reduces the risk of end-stage renal disease. It reduces the risk of cardiovascular death, non-fatal MI, and this hospitalization for heart failure. There were two trials. One was called Fidelio, one was called Figaro, and when you look at the outcomes, it supported these primary outcomes. But there's a big but that I'm about to tell you. And I want to tell you this because I've had people come to my office, usually from the pharma company, and again, I mean no disrespect to the company, trying to convince me to put all my CKD diabetes patients on this drug. And here's why I don't think we need to do that. So number one, in the trials, less than 7% of the patients that were enrolled were on standard therapy. The majority were on ACEs and ARBs, or ARBs. Only 7% were on ACEs or ARBs and an SGLT2 inhibitor. So when they added finerenone, the question is, would it have worked as well if they were already on what we call standard therapy? We're not sure. There's another trial called Confidence coming out. We're going to know more then, okay? Second of all, in one of the studies, the Fidelio study, the patients were much sicker. The eGFR average was 44 versus 68 in the Fidelio. The urine ACR was 92 average versus 35. The people in the trial that were more sick, more advanced CKD, they did better. So the question is, does finerenone work as well on somebody who's not as advanced with their CKD? What's the magnitude of benefit with regards to that? And again, I would argue here that patients that should be on finerenone, this drug should be prescribed by somebody who is very familiar with CKD, like a nephrologist, and it really right now should be reserved for patients who have CKD with diabetes, they've got heavy proteinuria, they're already on an ACE or ARB and SGLT2 inhibitors, unless they can't tolerate them, then you consider finerenone. So please, don't prescribe this drug willy-nilly. The evidence is not there. Full disclosure, I was on the CADTH committee that looked at this. We looked at this evidence very carefully. I think we're going to learn more about it, but for now, if you think someone's eligible for this, just pick up the phone and ask a nephrologist. Okay, the outpatient nephrology referral form is available to you online. You can check it out. These are some of the criteria for referral. We've covered most of them. Nephrologists will see people with kidney stones. They'll see people with refractory or secondary hypertension if you need help. They're always looking to help patients if they can help you out. But again, most of these people can be followed by you, and hopefully I've convinced you of that today. This is just to show you the sort of lifetime of a patient with CKD. Some people end up progressing to end-stage renal disease. Some people choose a palliative approach to therapy. They don't want renal replacement therapy. Just please remember, your relationship with your patient doesn't stop with the referral, just like it doesn't stop with your cancer patients after they get into oncology. I published a paper on this topic back in 2018. We're going to have to reboot it soon, but a lot of what I said today is in that article, minus some of the new drug stuff. So if you want to read about it, there's some cases in there, please feel free. Actually made the cover of CFPOs. My mother was very proud of that. There's, if you do the problem-based small group learning, there's a great module on CKD that I helped edit. It was written up very well, a nephrologist was involved. So if you're involved in this program, I would check out that module. And here are the take-home points. So CKD testing should only be applied to patients with a high risk of CKD in the absence of acute intercurrent illness. Don't do it in patients with a limited life expectancy. That's called identification. eGFR and urine ACR are the tests of choice. That's all you need. That's detection. And again, I've mentioned some other situations where you might want to order an eGFR. Most cases of CKD can be managed in primary care. I hope I've made that extremely clear today and you feel more confident about it. That's the management piece. There are times where you should refer to nephrology. I think I've given you that list. And hopefully this toolkit that we've created will help you along the way. More updates are coming. I went over them today. The hypertension aggressive therapy, that should be a conversation you have with your patient if they're appropriate. I won't repeat everything I just said about SGLT2s, but you can look at the summary on the slide. And again, with finerenone, it's for a very specific patient population, and I highly recommend nephrology's involved before you prescribe that drug. And I will now take questions with the few minutes I have left. Thank you so much for your patience today, and there's microphones if you want to ask some questions. I just have to make sure I can see you if you're going up to the mic. So if there's no questions, that was either the clearest talk or no one understood a word I just said today, but that's okay.
I do have a question.
Yeah, go ahead.
So just as far as the evidence for SGLT2 for CKD with diabetes or without, what are the numbers needed to treat? Because I guess when I'm explaining to patients, and I see a lot of the mycotic genital infections, and then I tell them about amputation, they're not very keen. So just wondering what the number needed to treat are.
It's a great question. You know what? I don't have that off the top of my head. It's an excellent question. So you're going to be disappointed with my answer. I think what I do with my patients, especially, so the patients that have diabetes, even if they don't have CKD, I tend to have a conversation with them if they have a history of cardiovascular disease or a history of congestive heart failure, and I talk about the fact that Diabetes Canada has recommended that this drug can be used to reduce those risks. I take the same approach when I have that diabetes patient or the patient with diabetes who also has CKD. I talk about whether there's a benefit of an SGLT2I. But again, in that conversation, I also look at their urine ACR. So if somebody's urine ACR is negligible, the question is, do you have to put all of those people on an SGLT2I? Some people would argue yes, because in the trials, not everybody had heavy proteinuria, and they still benefited with less of a progression of their eGFR. But the more their urine ACR is elevated, the more benefit they're going to get. So I have that conversation with them because, as you just said, there could be side effects, there could be weight loss, they could get hypotensive. So I do my best to try to weigh the pros and cons, and we have a conversation. I do use the Diabetes Canada chart to show them, because I want them to understand sort of what the standard recommendations are. But you bring up a great point. Like, you can't just say, I think the benefits outweigh the risks every time. You definitely have to have that conversation with your patient.
This is a little bit unrelated to your talk, so I apologize, but one of the things I encounter frequently in patients with CKD is anemia, low hemoglobin, and I'm always a little bit stuck on how much to work this up, how much to attribute it to the CKD, or do I really have to embark, if the ferritin is normal, into a total anemia workup, or when to just leave it?
Yeah, so again, you're not going to love the answer to this either. So could give a whole talk on anemia for sure. I'm probably very similar to you. If one of my patients has anemia, I try to break it down into, microcytic, normocytic, macrocytic. I try to do that first. If somebody has a normocytic anemia and their CKD is sort of starting to advance, there's a very good likelihood that it's related to the CKD. But again, it depends on the context of the patient. What's their history? Do they have a history of a reason to suggest that they might be at risk for an iron deficiency anemia? So I wouldn't make it as simple as just look at the MCV and you're fine. What I would suggest, though, is that what we say for CKD patients is as their renal disease is progressing and you get closer and closer to an eGFR of 30, you just want to check for anemia, because if it turns out they are becoming anemic, there are treatments for those patients. In some situations, sometimes they can go on iron therapy. There's some patients that still are eligible for EPO therapy. I leave that up to the nephrologists. I don't really get into that management. That's the best answer I can give you on that today. Is there somebody else? Yeah, go ahead. Yeah.
For patients who have no hypertension but CKD, we've been taught that they can also be on ACE and ARBs for renal protection.
Yeah.
Is there a minimum dose that they have to be on, like that they have to be able to tolerate for us to actually get a renal benefit?
Yeah, okay, so let me just make sure I got the question right. They don't have hypertension, right?
Right,
They
no
have,
hypertension.
They have CKD.
Yeah.
Yes?
Correct.
Okay. So this is where I differ a little bit from the guideline. So the KidneyWise toolkit says that if you have CKD and let's say you don't have diabetes and you don't have hypertension, I would only start those patients on an ACE or an ARB. So actually, I probably wouldn't start those patients on an ACE or an ARB, because according to the guidelines and the evidence we looked at, CKD alone with no hypertension, they don't necessarily need an ACE or an ARB, right? Because what we're suggesting is if you have CKD and hypertension and your urine ACR is greater than 30, they should be on an ACE or ARB, more to treat the hypertension. So CKD alone without proteinuria, I don't put all those people on an ACE or an ARB. There might be some nephrologists that argue with me on that. The nephrologists I worked with on the toolkit did not. But if they have CKD and diabetes, let's say, and they have increased proteinuria, whether there's hypertension or not, to answer your question, I always start them on the lowest dose of whatever ACE or ARB I want to choose. And everyone's comfortable with everyone they want to choose. I try to choose the one that's the cheapest, so the patient can afford it, all those things, because I don't think there's a lot of differentiation between the two. So let's say I'm using Ramipril, and again, I'm just using it as an example. I'll start them at 2.5, and then what I'll do is I might wait 3 months, and I'll check their urine ACR again. Your urine ACR will never go to normal. Once it's elevated, it's very rare that by putting them on therapy, it's going to go back to normal. It's probably always going to be a bit greater than 3. But what you're looking for is either a reduction in the urine ACR or that it's stable. But if you, for instance, put them on you're looking for a little bit of a reduction. If you get a higher urine ACR 3 months later, or even if it's stable, the theory is you keep titrating the dose up until you get to the max dose that they can tolerate. So either the urine ACR starts to drop, I'd probably stop there. If the urine ACR remains stable, you really should try to get them up to the max dose, because that will decrease the chance of that urine ACR getting worse. And then what do you have to look for? Electrolyte abnormalities. You have to make sure they don't get hypotensive, they don't fall and break a hip. But that's the advice that we're given, is that you try to get to the top dose, but you do it in a way that's safe for the patient. And if their urine ACR is coming down halfway there, I'd probably stop there.
Thank you.
Yep.
Just kind of adding to that, if you have somebody who's hypertensive, diabetic, CKD, significant proteinuria,
Yeah.
all of the above, and you have them on, like, let's say Ramipril 10,
Yeah.
is there any utility in increasing to Ramipril 20 to get added nephroprotection?
No.
Not really.
In that case, I would put them on an SGLT2 inhibitor. That would be the next move for sure, because we showed from the evidence of those trials in the patient you just described, they should definitely be on an ACE or an ARB and an SGLT2 inhibitor. That's sort of the standard of care. It's a standard of care for people with CKD and diabetes, sort of period. Some people would argue that adding the SGLT2 is even more important if they have that proteinuria, their elevated urine ACR. Although again, in the trials that I showed, even if your urine ACR was like not that high or relatively normal, you still had the benefit of decreased progression to end-stage renal disease. So I wouldn't go higher on the ACE or ARB. Once you hit the top dose, assuming they can tolerate it, add on the SGLT2 inhibitor, go over the benefits and risks, and monitor.
Thank you.
Yes, go ahead. Sorry.
So I'm wondering, what's your approach once you establish that they do have CKD, but they don't have diabetes or high blood pressure in terms of differential diagnosis for the CKD?
Oh, excellent. Okay, so just let me get this straight. So you're saying if you diagnose them with CKD, but it's not due to diabetes or hypertension, how do you find out what it's due to?
Exactly, as a primary care physician before you send them to nephrology,
Yeah.
if you're not sending them.
So it's an excellent question, okay? So the answer is, in the majority of cases, remember, people as they get older, their renal function decreases. That's just the natural way of human beings. So sometimes it can just be to the fact that due to age, their renal function goes down. So sometimes you can have CKD and it's not due to either diabetes or hypertension. However, I always think about what's on the differential diagnosis, right? So the investigations that we ask you to do, like the urine, routine, and microscopy, we ask you to do it to rule out one of the diagnoses that we may not see that often: glomerulonephritis, some sort of inflammatory condition. IgA nephropathy is another one. If you're not seeing anything on the urine RNM, and like, it's probably not one of those diagnoses. And then you have to think about other things like, okay, is it polycystic kidney disease, right? So sometimes you'll order an ultrasound once you've made a diagnosis to determine if that can get you closer to the cause. And then sometimes you can get fooled, as I said before. You think they have CKD, but it turns out it's not CKD, it's an acute kidney injury. So if it's a male, maybe it's because they weren't telling you they're peeing 10 times overnight because they're embarrassed, and they have a post-renal obstruction. Then you do an ultrasound, you see signs of obstructive nephropathy, and if you correct that, all of a sudden they don't have CKD anymore, right? Or maybe if they do, it's a lot better because they've had some damage, but it's a lot more stable than you think. So you always have to think about what could be causing it. But sometimes you won't find a cause, and the reality is if you don't find a cause and they're not progressing, it probably doesn't matter. Like, I wouldn't send someone to nephrology if they had stable CKD and I wasn't 100% sure what it was. You can ask the patient if they want to know. I doubt the nephrologist would do a renal biopsy on somebody that's not progressing, depending on the circumstances. You could always refer, but if they're stable and you've done your workup, you can sit on it for a while and not necessarily have to worry. If they start to progress, I think that's a different story.
Thank you.
Is there anyone else at the mic that I don't see? Yep, go ahead.
I have one more quick question. So you talked about monitoring creatinine and ACR for patients with chronic kidney disease. Mm-hmm. And one of the bigger issues I've been having, and maybe I'm just checking it too often, is managing electrolytes and extended electrolytes in this population. And that's often when I'm starting to feel uncomfortable and thinking, do I need to refer them to a nephrologist when there's those abnormalities? Is there anywhere that you'd recommend for further education or like guidelines for that?
Yeah, so in my own experience, the most likely electrolyte abnormality you're going to see in CKD, number one is potassium. So hyperkalemia can occur. As patients progress, their electrolytes can go out of whack for many reasons, but most of the time, if they're not at a point where you're referring them, the question is it something we've done? So you always look at their list of medications first. What have you put them on? What are you treating them with? Do any of those medications potentially can cause an increase in potassium, like really important? One example I can just give you, it's a common thing, is that if somebody's on an ACE or an ARB, let's say, and they get a UTI, let's just say maybe they have chronic kidney disease, if you put them on trimethoprim, sulfamethoxazole, or Septra, that has a significant increased risk of interacting with the ACE or ARB, and the potassium will go through the roof. So you might think, oh, this is because of the fact that they have chronic kidney disease. It might just be because we've induced an acute kidney injury. So always think about when you get an electrolyte abnormality, is it really due to the chronic disease or something else? So always look at meds. I think the second thing is, if you do have an electrolyte abnormality, you look at your meds, you look at the whole picture, you're not sure what it is. I, like you, I'm not an expert in that. I usually ask for help. So you could ask your local pharmacist first to make sure you haven't missed something with the meds, if you have that relationship. I do a lot of e-consults in those circumstances too. So if the electrolytes aren't to the point where I have to send them to the emergency department, I'll probably send an e-consult. I usually, again, I'm in Ontario, I usually get a result within 48 hours. And the other thing too is that if you ever do get an electrode abnormality that's not to the point where it's critical, but it's out of whack with what you expect, repeat it quickly. I've seen a lot of potassiums come back slightly elevated, and I repeat them, and then they're fine. And I've been told that sometimes if the blood sits out too long, the lab person doesn't pick it up in time, sometimes it can throw things off in terms of hemolysis. But again, if you're ever unsure, please contact your local nephrologist. They will be so happy to hear from you. They can bill sometimes for telephone consults. No one will ever get mad at you if you have a question related to somebody's kidney disease that you can't answer. They'll probably get mad at us if we don't refer. I tend to get a lot of feedback on that, more than over-referring for something that clearly you've tried to figure out and you just haven't found an answer.
Thank you.
I have a question about starting ACE and ARB and finding that the creatinine increase or the eGFR decrease.
Yep.
What do you generally do?
Okay, so everyone needs to be comfortable with the fact that when you start those drugs, you can expect up to a 25% decrease in either the decrease in the eGFR or increase in the creatinine. So up to 25%, I actually don't get worried about it at all. You know, I might repeat it again instead of every 6 months like we talked about. I might repeat it again earlier just to reassure myself that when I caught that result, it's not continuing to go down. So I might do it again in 2 weeks or a month later. But up to 25% you can expect. You just don't want it to be more. If it's more, I actually put the drug I've just started them on hold, and I try to figure out what else I need. Most of the time, you have to rule out renal artery stenosis. You can speak, depending on the test you order at your local hospital, there's a CT type test that can be done. You would want to rule that out first. And if that's normal and you still can't explain why they had that reaction to the meds, I usually ask nephrology what they would do. And sometimes the nephrologist will say, thanks for calling, I think you're overreacting a bit. You can put them back on, monitor it, but at least you have that co-management confidence that you're not putting the patient at harm. And again, like, we're all very busy. It's easy for me to stand up here and say, I pick up the phone or I send an email. It takes time, it takes effort. It's more admin work for you, for sure. But I think taking that extra time to find that answer is well worth it to the patient, because otherwise you're stuck in a situation where there's a drug you want them to be on, but for reasons that you don't understand, they're not tolerating it. So what's your next move? Do you switch the drug, lower dose? What do you do? Nephrology is usually very, very good at helping out with those questions.
I'm going to ask the annoying question that you expected. Hypertension Canada doesn't ask for an ACR. They just want a urinalysis.
Yeah.
Can you speak to that difference? Because I was not asking for ACR in my hypertensive patients.
Okay, yeah, it's a great point. So you know what? I'll have to send something to FMF on this. So I'm not suggesting you're incorrect, because I know what you're speaking about. The last time I took a deep dive into Hypertension Canada's guidelines, there is something in there about an ACR. The problem is, I think you're right. I think the messaging is inconsistent. So in some places they talk about, like, what'd you say, like a urinalysis or something?
It's clear, like in Hypertension Canada, they say ACR for patients with diabetes.
No, sorry, you're right. I apologize. Not for hypertension alone.
For hypertension
Got it.
alone, no ACR. And
Yeah.
now you've said ACR for anyone
Yep.
to do dépistage for CKD.
Yeah, no, for sure. It's a great question. The next time I run into somebody from Hypertension Canada, I'll have to ask them. I can tell you that KDIGO, which is the international guideline for chronic kidney disease, so they're very clear that you need a urine ACR even with just hypertension alone. Forget the fact that you might diagnose them with CKD. It's a great question, and I will have to look into that, or I'll try to find out why they haven't changed it. But I have to tell you, I think it's essential if somebody has hypertension to make sure they don't have CKD. And sometimes you will pick up CKD patients who only have increased urine ACR. Like, I've got a few patients that in my practice, their eGFR is fine, but their urine ACR is elevated, and I monitor them. And you know, you want to make sure it's not just from the hypertension, it could be from something else, but they do exist, and we have to follow them. So yeah, I think it should say it in there. I don't know why they haven't added it for everybody with hypertension.
I have a question that might be simple and easy to answer, but for my younger patients, do we just simply go off of the ACR? Because a lot of the times they won't calculate the eGFR when I order the creatinine. Are there any creatinine-based cutoffs that we could use?
Sorry, can you explain that? Say that one more time.
Oh, I had a younger patient, I think like 20, whose eGFR was great, but his creatinine was terrible.
Their eGFR at age 20 was under 60 consistently for 3 months?
No. Their eGFR was okay, but their creatinine kept rising.
But if their creatinine's rising, how is their eGFR still normal?
Sometimes too, for really young patients, my lab won't even calculate the eGFR for me.
Yeah, so if the lab won't calculate the eGFR, and you're worried that the creatinine is higher than it should be, then I would do a creatinine clearance. Because again, I give a whole other talk on this, but the creatinine clearance result is very consistent with the eGFR results unless somebody is really obese or really, really frail. So if you do creatinine clearance and the creatinine clearance is within normal range, I wouldn't worry about it. If it isn't, that person definitely needs a workup. All right, time is up. I'll stay here if you want. If you want to come and ask me, I'll stay up at the front. Happy to stick around. Thank you for all those that stuck it out for the entire time. Please fill out your evaluations, and thanks again.